Head and neck cancers constitute nearly 30% of all cancer cases in India, and early detection plays a critical role in improving treatment outcomes. Through this campaign, Head and Neck Cancer Early Detection Better Outcomes, being organized by Voice of Healthcare and powered by Lupin, we aim to spotlight early signs, risk factors, and the importance of timely diagnosis, all with the goal of driving awareness and action. Join me in welcoming our speakers for today, Dr. Chandrakanth, MD, Academic Head and Medical Oncologist, Narayana Superspeciality Hospital, Kolkata. Welcome, Dr. Chandrakanth.
And thanks for having
Doc-
me.
Welcome, sir. Dr. Sudeep Das, Consultant and HOD, Medical Oncology and Hemato Oncology, Manipal Hospitals, Kolkata. Dr. Sudeep. Okay, he would be joining us. Dr. Priyadarshini Nayak, Consultant and HOD, Medical Oncology, Some Ultimate Medicare Hospital, Bhubaneswar. Dr. Priya, welcome.
Yes, good evening. Good
Good
evening, everyone.
evening. Good evening. Dr. Adil Hassan, Consultant Medical Oncologist, Apollo Excelcare Hospital, Guwahati. Welcome, Dr. Adil. So there is some network issue. Dr. Adil, can you hear me? Please unmute yourself, sir. Yes. So can you hear me, sir? Okay. So Dr. Chandrakanth, I think I'll start with you because your audio video both were clear. So in your view, sir, how can opportunistic screening during routine ENT and medical consultation improve early detection rates?
Right, ma'am. So, am I audible?
Yes.
Right. Okay. So, first of all, we need to understand what is screening. Screening is searching for a disease in a person who is not symptomatic. That is screening. Okay. Searching for disease in a asymptomatic person is called screening. Left में डाल देना भाई इधर.
Dr. Chandrakanth, can you can you hear me? I think we have lost his voice. Dr. Adil, please unmute yourself, Dr. Adil.
Hi, madam. I hope I'm audible now. Yeah, there was some
Yes.
technical issues from my end. I'm very sorry for that.
Right. Okay. Am I audible right now?
Yes, Dr. Chandrakant, you'll have to start then. You're
Right,
audible,
ma'am.
please.
So yeah, you were asking me specifically about screening. So I was just defining what screening is. Screening is for searching a disease in a person who has no symptoms. That is screening. And you specifically mentioned opportunistic screening. Opportunistic screening means a person goes to an ENT surgeon or to a general doctor for some other complaint. For example, he went for fever, he went for headache. So during that, you will take an opportunity and you will screen whether this person has a higher tendency for cancer. This is what is opportunistic screening. It is very important because what we do in screening is in head and neck cancer is a visual inspection of oral cavity. Okay, for those high risk individuals, who are those high risk individuals? Who are those individuals at high risk of developing head and neck cancer? They are the ones who have high risk behavior, like they have addiction to any form of tobacco, both smoke or smokeless tobacco. They are high risk. Alcohol is a high risk. Okay, and any high risk behavior, if they are, these patients fall into a high risk category. We need to remember that in head and neck cancer doesn't happen overnight. Head and neck cancer will give you lot of signals before it actually becomes cancer. For example, it will give you around 6 months to 1 year time when it actually becomes cancer, and there are something called precancerous lesions. For example, a leukoplakia, the what we call as a white patch, erythroplakia, a red patch. These are precancerous lesions. Opportunity. Either take them in a routine consultation or opportunistic screening. Take this opportunity, have a visual inspection of the oral cavity, whether it is a white patch or a red patch, and also try and find out any lymph nodes are there in the neck or something. So by doing this, we will be able to pick up diseases at an earlier stage. And we have excellent evidence. At least we have three randomized trials. One is from Kerala, that is from the Indian subcontinent. We have US studies in
Again, there is some network issue, and I think Dr. Chandrakanta very well explained that opportunistic,
right.
identification
So
of
right,
certain
right. So all these
networks.
studies suggest that screening can pick up cancer at an earlier stage. And we all know the famous slogan, cancer, if diagnosed early, can be completely cured. So this is my take on opportunistic screening in head and neck cancer, and it must be implemented. It picks up cancer early, and we can diagnose early, and we can cure larger number of patients. Remember, the moment it is stage 3 or stage 4 and beyond, it is very difficult to cure these cancers and also to have a good functional state. So therefore, opportunistic screening is the way to go, especially in high risk individuals. Thank you. Thanks again for patient hearing, and apologies for a technical glitch and disconnection in between. Thank you.
Thank you, Dr. Chandrakanta, for letting us know that there are certain precursor lesions like erythroplakia, leukoplakia, which can be easily picked up with the help of opportunistic screening. And definitely, whenever a patient goes to a doctor for any other complaint, we can just check the lymph nodes and these lesions. So, my next question would be to Dr. Priya. What are the most
Nayak,
frequent early
Chandra Business.
signs signs and symptoms of head and neck cancer that patients often ignore, leading to delayed diagnosis?
Yeah, it's a very nice point. I mean, to discuss. Generally, we find that some patients, who are having consistent sore throat, they seem to be sort of cold and keep on ignoring the signs and symptoms. So it can be actually early sign of head and neck cancer. Second, there can be ear pain, which patients ignore. They think it will be infections and go repeatedly do consultations that yet the people here pick up and find no clue until the patient has. Second, there can be a painless lump, in the neck. Patient keep on ignoring since it's painless. They think it would go away. They keep on ignoring, and it can be actually a sign of head and neck cancer, maybe a cavity cancer or very laryngeal cancer. So they keep on ignoring that. Again, that can be persistent change in voice. Patients keep on ignoring, and they get research also. So since it's painless, they keep on ignoring. They think it's vitamin deficient or something, and the very and it's been found that there is at least from 4 to 6 months delay between the appearance of first signs and symptoms and presentation to the hospital.
All right. And can you suggest some simple red flags that general practitioners should always check during consultation, because they are the primary focal point where patient comes first and then they are referred to the oncologist?
Yeah, generally, for general practitioners, red flags can be like, if patient is a smoker or a alcoholic, like his tobacco chewers, they should check for they should do a routine like oral cavity. So if there is some like any ulcer or any red patches or white patches, because these are three cancer regions, and it is seen that around 25% of the three cancer regions they actually uh, uh, become cancerous in later stages. So they should sort of cavity thoroughly. Again, if there is the patient is a smoker or tobacco is complaining of ear pain, or that is change in voice, the persistent change in voice, most of the general practitioners, most of the patients ignore it, thinking it to be cough or cold. So the most common signs, so they should take it as a red flag sign. Again, if there is some ulcer or something, they should again look for it, high care center.
Right. So, my next question would be to Dr. Adil. How significant is the role of HPV awareness in modifying early detection and preventive strategies for head and neck cancer?
Yes, madam. Especially in cases which is not associated with smoking and alcohol, HPV plays an important role in the pathogenesis of oral cavity cancers. Specifically in the posterior part of the tongue and in the oropharynx, we say, or in the tonsillar area, around 10 to 15% of the cases are because of HPV. So HPV is not only important for preventing the cervical back cancer that we know, it is also very important for preventing the oral cancer as well. So it is very, very important.
And should, according to you, HPV vaccination campaign in India also address head and neck cancer risk alongside cervical cancer prevention, as you just mentioned?
Yes, yes, madam, absolutely. And definitely, I would agree. Along with the cervical cancer, prevention, I think we should encourage, taking the vaccines for boys as well. Right?
So, Dr. Sudeep Das, uh, uh, please say hi because I need to check the audio. Dr. Sudeep, unmute yourself, sir.
Hello, madam. Yes.
Yes, yes, I can hear you now. So, Dr. Sudeep, what strategies can hospital adopt to educate high risk population, for example, tobacco user, about warning signs?
Pardon?
So, what
What
strategies
measures?
like can
Yes.
yes measures hospitals can take to educate tobacco users about early warning signs of head and neck cancer?
Ma'am, it should start from school. That the normal citizens, they should actually should not start the habit of taking tobacco. It should start, the education should start from school. It should be incorporated in the school curriculum, so that from very young, the young minds, they understand that tobacco in any form, not only chewing, also smoking, it can cause cancer. Not only oral cavity cancer, it can lead to pharyngeal cancer, larynx cancer. Tobacco is related to gastric cancer. We know that it is related to other cancers like renal cell carcinoma, kidney cancer, bladder cancer, and of course lung cancer. So we should educate the young chaps that they should not start taking tobacco from the beginning. If anyone is already started having tobacco in any form, in the hospital should actually first start with educating, their staffs, and they should also circulate um, the audio visual information in the hospital premises, or they can organize, they can distribute pamphlets against tobacco, and they can also organize camps in the mahallas, in large small towns. So who are taking tobacco, if even if they quit tobacco right now, though the risk of getting cancer will not become zero, but it will come down drastically from whatever risk they are exposed. They are actually presently they have the risk at present. who are active smoker. So by quitting tobacco, they can minimize their risk, though it will not become zero. It will not become zero like a normal person who have never had tobacco.
Right, sir. So, as you rightly said, that it should start from the school. What else we can do for community outreach programs so that tobacco, use can be decreased?
Yeah, so that can be it actually that can be done in various platforms. So there are responsibilities of not only hospitals. There should be responsibilities of schools, colleges, every corporate organization. The corporate organization like offices, they should arrange awareness camp in their premises. Like in big cities, there are large residential housing complex. The residential, the residential borders committee, they should come up and organize some awareness camp in their residential campus. So, and there are a lot of responsibilities of celebrities too. Unfortunately, Indian celebrities, they are getting more and more indulged in promoting tobacco, all form of jarda and tobacco, chewable tobacco. That is very unfortunate, I must say. So the celebrities should also, they have some social responsibilities, and yes, of course, there is scope for advertorial or campaign on newspaper and print media. Uh, there can be a show organized in audiovisual media as well. But the most impact comes when one is to one interaction, direct interaction. When the physicians, they directly reach out to reach the at community level, and they get engaged with large uh, citizens, like suppose a pensioners group or some employee group in a particular office or any club. So there's a lot of opportunities, and NGO has a very big role to play here.
Right, right. Rightly said, Dr. Sudeep. I believe that NGOs and other organizations can play a role. They can outreach the community about decreasing the tobacco use so that the major risk factor can be reduced. And it should start from the school, right from the school. Dr. Chandrakanth, can you hear me? Dr.
Yes, ma'am.
Chandrakanth. All right. So, Dr. Chandrakanth, how do you ensure balance between aggressive therapy and quality of life for head and neck cancer?
Right. So, head and neck cancer is a unique cancer when compared to other organs. You know why it is unique? If I have a hand cancer, if I have a leg cancer, I can be easily operated and put a prosthesis there. It is easy. Whereas head and neck is such a sensitive area where there are multiple functions involved in it. For example, seeing, talking, smell, taste, swallowing. All the sense organs are concentrated in the head and neck. So, therefore, head and neck is a unique cancer. So, therefore, not only curing cancer, but also maintaining functional status is important in head and neck cancer. Along with this, one more thing is we do not recognize other people by looking at their feet or at looking at their hand. We recognize by looking at their face. So it has social implications. So therefore, head and neck cancer is unique, and having a functionality and cosmesis is prime important. So therefore, what are the things that we have in the present day? So we have something called organ preservation strategies. So if you ask me 10 years before, if someone had a throat cancer, we used to remove the throat. and the person could not talk in his lifetime. He had to breathe through a tracheostomy. We used to do what is called laryngectomy. So now we do not operate the throat or the base of the tongue. What we do is we do a concurrent chemo radiation. By doing this, we preserve, we conserve the larynx. The voice box is conserved. So, this is one way of organ preservation, attaining functionality and cosmesis. And secondly, let's say someone has an oral cavity cancer, surgery is the way to go. But now, to reduce the morbidity of surgery, we have uh, the flaps. There is something called flaps where we took some other part of this, like thigh skin or skin from elsewhere, and we put it there to attain adequate cosmesis. And now coming on to radiation. Radiation, if you do, we used to do something called as a cobalt radiation, where it used to radiate a large part of the face or the neck. Now we have got something called intensity modulated radiotherapy, where we radiate and we contour only the affected area. Therefore, again, the cosmosis is optimal in these situations. So nowadays we are also having immunotherapy coming even in an operable head and neck cancer, where there is a 50% chance of achieving a complete response. So, a long way to go. I'm sure there will be a time where surgery will be less and less, local therapy will be less and less, and systemic therapies will take over. A bright way to go. Again, to stress that if you want to have the best cosmetic and the functional outcome, early diagnosis. As you very correctly mentioned, be aware of the danger signs. An ulcer that is not going away beyond a month, a change in voice, a difficulty in swallowing that is not improving beyond a month. All these are the danger signs that we must be aware about. Thank you.
Right. And sir, I would like to ask you one more thing that although you have told us about the treatment modalities and how these are improving day by day, and you are doing the organ preservation surgery, I would like to know that how do you, club speech and swallowing rehabilitation in your treatment plan while planning for head and neck cancer patients?
Yes, very important thing. So let us imagine we have got a ulcer on the tongue. Okay. So, and it's very painful. Imagine you have to bear it and you have to chew and talk. So, we would have experienced these many of times where we are not able to speak properly because of the pain and the ulcer. What happens in head and neck cancer patients? We have removed a part of the tongue and we have put a flap in that area. So now it's a sort of an artificial, a different nerve supply, a different feel. With this, having speech and swallowing is very important. So the key to this is uh, whenever you undergo a radiation or a surgery, whatever treatment you undergo, you must quickly resume to the normal activities. Not that when the treatment is going on, we will not consider them for physio or for speech and swallowing. We need to keep motivating the patient and we need to stress the importance of speech and swallowing immediately after surgery and also during chemoradiation. Otherwise, otherwise the big problem is if speech and swallowing is affected, the saliva starts pooling in the throat and that gets into the lungs and the person will start having aspiration pneumonia, and we have lost a lot of patients because of this. So therefore the key is we have to motivate the patient for speaking and swallowing. What happens in radiation is these salivary glands, those glands which produce the saliva are burnt and they become permanently disabled at times. So when that happens, what we do is a simple salt and soda bicarb gargles. Just by doing that to keep the area wet and the lubrication is there. So just by doing this repeatedly and motivating them for speech and swallowing, and we have experts, we call them as occupational therapists or speech and swallow therapists. When we send them across to them, there is a significant improvement. So treating cancer is important. We have surgery, radiation, and chemotherapy, and also biologic therapy. All these are there to reduce the complications, but rehabilitation with speech and swallowing is extremely important. An organ that cannot function is as well as not having the organ. So, therefore, maintaining functionality by speech and swallowing involving appropriate facilities like the speech and swallow therapist, occupational therapist is extremely important. Thank you.
Right. So that is very important, and especially as you told that if swallowing is not proper, then it can lead to aspiration pneumonia. And by simply giving salt and soda, we can just maintain the area wet. And of course, occupational therapist can be involved to achieve this. Right. So, Dr. Adil, I would like to ask you that with biosimilars becoming more accessible, how do they impact affordability and adherence in long term oncology care for head and neck cancer?
Yes, fine. Madam, first and foremost, what do you mean by biosimilar? We know that, Dr. Chandrakanth just mentioned that immunotherapy and targeted therapy is kind of revolutionizing head and neck cancers and different cancers across the way how we treat. But unfortunately, in our country, almost more than 90 to 95% of the patients will not be able to afford this sort of therapy because of the cost factor involved. For example, one cycle of immunotherapy may cost around 2 to 2.5 lakhs for a patient. So in this situation, what happens whenever, say, a company comes up with a new drug after X amount of time, the patent of the company is no longer there. So a different company is also able to produce the same drug. So that is what we call as biosimilar. So definitely, I would say biosimilars means, of course, it is tested. It has its own testing, and it has to be approved by the drug authorities in the country and outside as well before it can be actually approved inside the market. So we know that this particular drug is equivalent to the original one which has come into the market, and the advantage of this particular molecule is the cost comes down dramatically, so it becomes much more affordable for the patients. And once a biosimilar comes into the market, we have seen even the original molecule comes down in cost dramatically, and thereby makes it much more accessible for most of these populations.
Right. You rightly said that cost is one factor. What other
Yes.
factors, influence your decision to switch a patient from a reference biologic to biosimilar? Cost is definitely there. What else?
Yes, madam. Madam, in general, if a patient is taking one particular drug, and if it is working well for him, in the middle of the therapy, I would not like to switch the therapy unless it is really really maybe cost is the only factor which I would think of while switching, because although there is not significant difference biologically, sometimes while adding a new drug we do see maybe some side effect profile may be a little bit different in the other drug as well. So, but the long story short, if a patient is able to afford, especially in a curable setting, and if he is already on the innovator molecule, probably I would like to continue. Or I would start with the biosimilar to start off with. Probably this switching thing in the middle of the therapy, I would not advise the patient. But
Thank you for your comment. Dr. Sudeep, can you listen to me?
Yeah, yes, ma'am.
Okay. So, what, according to you, are the key barriers to accessing advanced oncology care for head and neck cancer patients in tier 2 and tier 3 cities, and how can we address them?
Yes. So the first thing is the delay in diagnosis. Delay in diagnosis is one thing. And second is lack. Suppose even if it is diagnosed, the patient get diagnosed. Next comes the tri-modality treatment. There should be a good medical board, tumor board discussion for most of the patients. The surgical oncologist, head and neck surgeon, radiation oncologist, medical oncologist, and these specialists who are looking, who have vast experience in treating head and neck cancers, they should collaborate and they should discuss with this patient. Each patient is new. So many of the patient is getting suppose treated by individual surgeon or individual oncologist. I think that is where the tier two or tier three cities there's very lot of scope for improvement. Of course, there are patients probably who will not good eligible candidate for upfront surgery because the disease may have reached in a such stage. Probably they need some downstaging and a over enthusiastic ambitious surgery at the very beginning may not give you the optimal outcome. Maybe there can be a margin positive. If the margin is positive, then that our final outcome is jeopardized. Now the another issue is many tier 3 cities we don't have good quality radiation machine available, the linear accelerator available there. So what Dr. Chandrakanth was telling that we can preserve organ, the function of larynx or pharynx by chemotherapy and radiation concurrently. The patient may actually miss that opportunity where the radiation machine good facility is not available there. But the most important I will stress here is the good collaboration between the all the specialties. Head and neck surgeon, radiation oncologist, medical oncologist, speech therapist, occupational therapist, a good oncoradiologist who can identify who can give you technical informations that there is the tumor is very close to skull base. The tumor may not be actually operable. Even if you operate, there is a high chance that it will come out margin positive surgery. So it will be a futile surgery. Unnecessarily, we are will be offering a lot of toxicities, post-op morbidity to the patient. So that is the most important part, the collaboration between all the specialties under one roof. So that is in available in most of the tier one cities, but which is yes, many individual surgeon or many individual medical oncologists or radiation oncologists are doing very fantastic job in resource limited tier two or tier three cities, but we can improve the final outcome if we have better collaboration among all the specialties.
Right, sir. Sir, you rightly said that tier two, tier three cities may not be having linear accelerator, and as you said, that intensified, radiotherapy is the way where we can preserve the organ. Do you think that teleoncology can help us in any way to bridge this gap?
Yeah, why not? At least we can discuss with all the informations available at the beginning and chalk out the strategy. What should be the best strategy for this patient? Then what are the modalities he will require among these three modalities: surgery, radiation, chemotherapy, and
Right,
what
right. I
modality
think there is.
we are going to use, and what should be the order. That is also important. What should be the order? We can chalk out the strategy at least.
So on that, I just want to know that how is the treatment plan, decided for a patient? Suppose a patient comes to you, how do you decide that this is to be given or what has to be intensified?
We give tumor board. The head and neck surgeons And radiation oncologist, medical oncologist, we come together in a meeting room. The radiologist is already there on the giant screen. We see the images.
Dr.
Take
Sudeep.
account the important radiological, we take into account the important radiological findings, whether the tumor is very close to base of skull or it is involving important structures like pterygoid plates, or it is very close to hyoid bone, which are actually which make the patients unresectable. Now, if the node is there, how big is the node? Whether it is involving the carotid sheath, or and suppose if the laryngeal framework is already destroyed by tumor, even radiation oncologist can give his input that see even chemoradiation cannot preserve a good quality of voice in this case, so there is no point preserving larynx. uh, so it's better to go for a laryngectomy. So every case is unique case, and it's better to discuss among all the specialties with a good radiologist there.
Right, sir. So the tumor board comes to the rescue, and I believe it is a multidisciplinary approach, and every patient is unique. And I think you can decide among different disciplines that what is to be offered to a particular patient. So, Dr. Adil, how does oral hygiene and dental care play a role in prevention of head and neck cancer?
Definitely, madam. I think oral hygiene is quite important, especially not just for prevention, even after the like when we are giving the treatment also for the patient. It is important for us, to prevent the infection because once we're giving radiation and chemotherapy, that particular area is quite susceptible for infection. So definitely, I would say oral hygiene is not just important for the prevention part because, especially because we know that the sharp tooth, if a tooth is there, which is like causing constant irritation to the inner part of the mucosa, what we say, that in turn can lead to cancer, madam. So definitely that I think is very important, the dental hygiene. And plus probably in the treatment part also we need to make sure that the patient maintains good oral hygiene.
That's right. So if there is a dental problem, they should go to the dentist, and especially the sharp tooth, which is causing irritation to the mucosa, can lead to ulcer
Right.
formation. And what according to you, the other strategies that can be effective in reducing tobacco and alcohol-related head and neck cancer?
I'm sorry, madam. What are the strategies that can be
What's
used to?
what to reduce the tobacco and alcohol-related head and neck cancer in India? What strategies can we take?
What strategies? I think sir actually pointed out, earlier. One, I think, unfortunately, like he said, celebrities and we have seen endorsing tobacco. I think like that it's an important message that we need to promote that tobacco is responsible for almost 50% of the cancers in our country. The people who are willing to quit tobacco, I think we should definitely encourage them. I think, bringing the message to the masses is again very important because whenever we're thinking of these strategies, we always concentrate on the urban areas. I think we should concentrate on the rural areas as well because not just, cigarette smoking, the BD smoking and the smokeless form of tobacco is also very, very important. So often this particular thing is quite ignored. In fact, we see in the Northeast, probably head and neck and the lung cancer and the esophageal cancer is one of the most important type of, preventable type of cancer. So I think it's very important, and I think NGOs plays a big part. And any patients who come to the hospital also, we can probably distribute the pamphlets. People who are wanting to quit tobacco, we can definitely encourage them. So I think all of these measures are very important, which will help us, going one step ahead in bringing down the tobacco menace in the country.
Right. So before I take, the closing remarks from both of you, I would like to burst certain myths around head and neck cancer. So one myth that is very prevalent is that only smokers get head and neck cancer. So the fact is, it's not true. HPV infection and other factors can also cause head and neck cancer. There's another myth that many head and neck cancers are painless in early stages. So that's not true. Pain doesn't mean that it's not a cancer. Cancer treatment always leads to disfigurement. This is another myth. So, fact is that modern surgical techniques and therapies focus on function and appearance preservation, as we have already discussed that radiotherapies and chemotherapies can lead to organ preservation. One myth is that early stage mouth cancers have high cure rates with appropriate treatment. So, this may not be true that mouth cancers are not always curable. So, you have to consult your doctor, medical oncologist, and there are tumor boards to address this. And every patient is unique, as we have seen, and treatment plan would be, made by the oncologist only. Another myth is that head and neck cancer happens only to elderly people. The fact is, younger adults can also be affected, especially if HPV associated cancer is there. So, with this, I would like to take closing remark from everyone. So, Dr. Adil, do you want to convey anything to our audience about head and neck cancer?
Madam, I think we have spoken earlier also regarding the HPV vaccine. Probably, we need to be aware that just not just smoking and alcohol contributes to oral cavity cancer. It is also the virus, that is HPV virus, which is causing. And also, you did mention about the dental, the importance of dental hygiene and the sharp tooth. Probably the masses, they don't know much. They always associate head and neck malignancies with smoking and tobacco. Probably this one message is very important.
Rightly said. Dr. Sudeep, are you there?
Yes,
So, any,
yes,
yes, please give us some closing remark and any message to our audience.
yes. But it is not a one day job. The continuity is the most important. Involving more and more people. It's not a job of a physician or an oncologist. It is a job of the school teacher, the headmaster of the local high school, the principal of the college, the local bureaucrats, the district bureaucrats, the president of local club. All should come together. You know, it is, and it should. We should form a social campaign, and it is a continuous process, like it was a continuous process against leprosy, there was a continuous process against tuberculosis. So similar way, at a point of time it was a continuous process against HIV. So it is a continuous process. If you want to really see the change, it will take at least 1 decade, and everyone should join, starting from bureaucrats to starting from all the celebrities and the teachers in every profession. It will take time. It is not the job of only some one or two NGOs or some physician or oncologist. The large participation and persistence, the continuity, that is the key actually.
Exactly. Large participation and continuity. This is what is required for the awareness. Dr. Chandrakanth, are you there? Sir, any
Yes,
closing
ma'am.
remarks?
So I think Dr. Sudeep and Dr. Adil made it clear. So, well, if someone asks, what is the reason why I and you are going to die? And the most common reason is cancer. So, cancer is a reality and it is going to happen to each one of us. And if someone smokes or if someone uses tobacco, the chance that he or she will die of tobacco is 50% chance. That is the reason for death due to tobacco. And tobacco is the most preventable cause of cancer. So, therefore, the key is not to start using tobacco. And if you have started, better late than ever. You can stop right now. The moment you stop, If you are able to stop for 5 to 10 years, your risk comes down to the pre-smoking levels. So therefore, no tobacco is the way to go to prevent head and neck cancers. And be aware of the warning signs of head and neck cancer. Don't wait for a simple small ulcer that is not going away beyond a month is a warning sign, and you must go to a doctor and take an early treatment. Don't wait until your face becomes swollen or you get lymph nodes in the neck. So be aware of the warning signs. And once you get diagnosed, do not hesitate for biopsy and go ahead with the standard treatment prescribed your doctor. It is not that you will lose cosmesis. Cosmesis can be preserved in the present day with sophisticated treatment options. Thank you.
So, on that note, I would also like to conclude this session that say no to tobacco, and we need lots and lots of participation from everyone to spread this. And this is an awareness campaign like this. We can have more and more communities. We can have more and more NGOs, participating and spreading the word around. And it should start right from the school. Thank you so much for joining us today in this awareness session. Thank you.
Thank
Thank
you.
you, man.
Thank you.
Thank you, ma'am. Good night.
Good night.